Welcome. My name is Chris Schmidt. I'm director of the University of Pittsburgh Medical Center, Department of Orthopaedic Surgery, Shoulder and Elbow Fellowship. I'd like to thank Dr. Fu for his generous support of creation of the fellowship. In fact, Dr. Fu named this fellowship. Dean and I, my partner, decided to start this fellowship in 2013. We were very involved with upper extremity training for over 20 years, each of us. I realized that shoulder surgery is special. It takes a lot of time to learn how to do it correctly. And so we really developed this fellowship on that premises to spend some time with one fellow and really train him well to be a great shoulder and elbow surgeon. Now, this is our country symbol, and if you notice, it goes E pluribus unum. And what that means, it means out of many one. And it took us a long time to design this fellowship, like 7 years. And the attending physicians are 4 people that are great teachers, and they're very enthusiastic and very supportive of our fellow. There's Dean, there's Albert Lynn, there's Patrick McMahon, and myself. Now, not only does a good fellowship need great teachers, but they also need great support staff. And you can see we have a fellowship director, we have a fellowship coordinator, and we have a fellowship pretty much librarian. And they're all circles. There's Beth, Angie, and Anthony. And we also have further support. We have research support from our dedicated shoulder and elbow lab. And there's many people. This is Luis is our current fellow, and this is his welcome dinner. And you could see there's many people involved in training Luis, our fellow. So out of many, one. And our fellow is the benefit of all these people graciously helping to train them and make their lives pretty worthwhile here in Pittsburgh. So our goal is to assist the fellow into becoming a first-class shoulder and elbow surgeon, support you or the fellow throughout your career, and basically have a good time, have a fun year and get to know you and you get to know us. So goal 1, a first-class shoulder and elbow surgeon, you need to teach them. So we have anatomy lessons. And anatomy is key. All these dissections, you have to know your anatomy in order to be a good shoulder and elbow surgeon. And then there's didactics. And during this, there's money set aside for you to go to 2 or 3 courses during the year. Our first fellow, Dr. Zink, went to the Tampa course and also went to a coding course. And then we got hit with COVID-19, but he was scheduled for another course. There's a wet and dry lab for your practice. There's hands-on office and surgery. And there's research opportunities, both clinical and mechanical in our lab. So the first part is anatomy. Remember, a surgeon is a clinical anatomist and really nothing more. And we're really take a lot of time and pride in teaching you shoulder and elbow anatomy, the nerve anatomy, the vessel anatomy, bone, tendon, and ligaments. And here's our anatomy lab. You can see it's our anatomy topics, and you can see it's pretty comprehensive. So here's some examples. We do an elbow anatomy, and we dissect out the posterior anastomosis nerve. We identify all the nerves. We look at closer. We look at the shoulder nerves, the subscapularis nerve. You can see out we have the transverse scapular ligament, spinal glenoid ligament. We look at the relationship between the capsules. We look at the relationship between the rotator cuff and the nerves, and we really hone it down. We also teach arthroscopic anatomy. We look at the transverse scapular ligament arthroscopically and how to do an arthroscopic subscapular nerve decompression. We look at the anatomy of the anterior capsule, or spirit capsule, I should say, and we look at the footprint of the rotator cuff. We look at the biceps tendon, the short and long head. We want to know as much anatomy and teach you as much anatomy as possible. And we spend a lot of time with you on anatomy. All 4 of us do. So then there's didactic conferences. We have a shoulder and elbow conference, dramatic. Since the COVID, we've been having it with Zoom. And we have like 22 people annually on this conference, but we still question the fellow, and it's still fellow-centric conference. We have an indication conference once a week, especially joint planning, how we're going to put the implants in. We have anatomy lab. We have a wet and dry lab. We have journal club once a month, and it could be at a local restaurant, my house, or country clubs. We have a research conference to guide you through your projects and just general research topics. And of course, if there's shoulder and elbow at UPMC, we have grand rounds Department of Orthopedic Surgery. Like here's an example of didactics. We split the time with the fellow. So the fellow's on a rotation of every 1/5 conference. Otherwise, it's Dr. McMahon, Lynn, Saterianis, and myself giving these talks. And they're national level quality talks. We have journal club. We spend a lot of time with the journals once a month, and this is at a country club. And it could be intimate or it could be large with 10, 15 people. We have dry time where you spend time practicing without a cadaver, and you get honed up with the instruments and arthroscopic technique. You learn triangulation. You all come in with different levels of skills, and we try to get you up to date to where we want you, so you can be a good shoulder and elbow surgeon, or a great one. We have a wet lab that you'll see a video on later that it shows you that after you get to the dry lab, you got to practice with cadavers, and you get your own cadavers, so you get some time to do the wet lab. So the other question we're getting asked is about rotation schedule, and this is kind of dynamic, but like currently this is how it works. Like on Monday, the fellow's with me in the OR, and they rotate every 3 months. So Monday, fellow's with me in the OR, then the fellow spends time with Dr. Lynn. Wednesday's with me in the OR, and that's really an arthroscopic day. Thursday in the office, and Friday is free time, except for all Fridays, once a month throughout the year, you spend time with Dr. Pat McMahon and a shoulder-specific surgery day. And then the next block is with Dr. Saterianis, the office, and then me on Wednesdays in the OR, and then Tuesdays and Thursdays in the OR with Dr. Saterianis. And then the schedule goes back and it rotates every 3 months. So this is our schedule. So there's time with Albert Lynn for 6 months, time with me throughout the year, time with Dr. Saterianis for 6 months, and time with Pat McMahon throughout the year. So we try to spread the time, and you get time on Fridays for elective time to practice your skills and to do your research. And we're flexible. If there's a great case like a total elbow revision, we're very flexible in having you participate at that case no matter who's doing the case. It's really designed to teach the fellow how to be a great surgeon. So there's hands-on in the office, like instability cases we do. This is a patient of mine who played in a state championship basketball, and he had a revision, actually ladder J, and here he is. And he went on to play college basketball. We get hands-on time where you have a guy has a disc instead of pseudoparalysis. A patient here has a pectoralis major tear. We see many of these throughout the year. The fellow should be seeing about participating in at least 3 pectoralis major repairs throughout their time. We have distal biceps tendon ruptures. I see a ton of distal biceps, but Dr. Saterianis also does a ton of distal biceps repairs. We see people with pseudoparalysis all the time. We see people, there's like this one. We also see, elbow dislocations, elbow trauma with an exiguopressic injury that we had to reconstruct the central band and repair the collateral ligaments in the elbow. Hornblower sign, we see it pretty much every week. We get you honed in on the distal biceps tendon, like you see partial tears of distal biceps tendon. It's illustrated on this one where the long head's intact and the short head's ruptured distally. And you can see that a short head rupture. You see triceps tendon injuries. So you see injuries of the biceps as well as the triceps, and should be able to fix these. You see complications of distal biceps rupture, such as this large heterotopic bone. You see this guy who's got a loose prosthesis that's sticking out of the front of the shoulder. And you can see that x-ray on your left. It's a loose prosthesis that's loose. And when I hadn't revised it and reconstructed it with a reverse total shoulder reconstruction. You see cases like this on your left with the implants, straight up and a glenoid fracture and reconstruct it and with 3D imaging. You see this lady with dysplasia of her glenoid. See typical avas necrosis. You see on your left, you see a patient of mine who had a soccer, was a complete college soccer, had a long thoracic nerve injury, and I did a muscle transfer, pectoralis major, and you could see her out now 5 years, and now she's a high school gym teacher, and she has a family. You see this commonly, calcific tendinopathy. You get in there and we decompress it, and if we need to, repair the cuff. You see this, a bad fracture. And this is our first fellow last year, Tom Zink. And you can see him bonding with the patient with the bad fracture. And this is what it's all about, having fun, get to know our patients, and doing high quality medical care. So you get a hands-on surgery. You get open surgery and you get arthroscopic surgery. Now, our first fellow was Tom Zink, and it was during the COVID year, and he still managed to do 427 cases. 351 of these cases were shoulder and elbow specific cases, 20% elbow. I mean, he did 74 elective shoulder arthroscopy or shoulder arthroplasty during the COVID year, 155 elective shoulder arthroscopy, when that means rotator cuff repair, shoulder instability, shoulder arthroscopic biceps, etc. We got open repairs. We have muscle transfers, arthroscopic assisted, lower traps, latissimus dorsi. He does elbow cases, 64, total elbow arthroplasties, revision total elbows, elbow arthroscopy, osteochondral arthroplasties, of course distal biceps repairs, some endoscopic. So this is a patient, this is a dying operation, but we still do a hemiarthroplasty for some people. This was probably a little old right now for that, but for younger people, we still do it. Of course, we do reversal arthroplasties for fracture. This is a local physician, and you can see a 2-year follow-up on reversal arthroplasty. So on your left side is AC joint ligament reconstruction. On your right side is a medial collateral ligament reconstruction of the elbow. So we do medial collateral ligament reconstructions, lateral collateral ligament reconstructions as part of the elbow cases. Dean does an open anterior biceps repair. I do a posterior repair, as you probably know. We do open, sometimes we do arthroscopic subscapular nerve decompression. Sometimes we do it open. And the fellow, would be, should see these cases because we see him all the time. So you also get arthroscopic nerve decompression. So here's an example of a transverse scapular ligament release, and you can see after we resected the transscapular ligament, you can surely see the suprascapular nerve. We also do, arthroscopic rotator cuff repairs, distal clavicle repairs. We do all size arthroscopic repairs, as you can see in this video, or these 3 videos. We do arthroscopic subscapularis repairs. We do a lot of them. I think our last fellow did about 30 to 40 arthroscopic subscapularis repairs. This is a simple repair with a dislocated biceps tendon and a tear about the top 40%, but we do when they're completely off, and we put the scope in anterior when we use anterior accessory portals. We do arthroscopic assisted muscle transfers. So here's an example of latissimus dorsi. I also do lower trap with a tensor fasciolata extension. It's interesting. Here's a patient with an arthroscopic latissimus dorsi transfer. He's got like a 2 handicap in golf, and he can juggle. And it took him some time to learn how to juggle because he learned how to retrain his latissimus dorsi transfer, but he eventually got it and learned how to juggle. And we do the latest techniques with therapy with biofeedback and latissimus dorsi. So here's another thing that's it's something close to me. I'm pioneering how to do an endoscopic distal biceps repair, and you could see you could safely drill the holes and pass the tendon from front to back and repair the tendon solidly down the bone. Now look how it moves endoscopically. And that's going to be the future of distal biceps repairs with these small scopes that they're developing. We use the latest guides. We do 3D imaging, and we do planning appropriately, and then we have an indication conference and review the cases ahead of time so we can execute them using the 3D imaging at the time of surgery. And the fellow is intimately involved in this. And you can see here's a reverse shoulder arthroplasty after 3D imaging. It looks perfect every time. We also use 3D imaging on when we do total shoulder arthroplasties. It's a different company, but we use what we think is the best available at the time we're doing the case. And we also are doing the VR, and we're going to get involved with that technology. And you can see this is regular using the patient-specific guides, and you can see the glenoid. And just as we take our pride and have great exposure and teach the fellows how to do it properly, great exposure, no blood, and solid cement technique. And you can see we want backside coverage, as you can see here. And we'll do even wedge glenoids for patients that need the wedge glenoid. See, here's a wedge glenoid again, bone dry, solid techniques. And this is what our final outcomes is, and that's what we expect our fellows to learn how to do this the right way. We also do, my partner does, further, 3D imaging. We have a radiology department that can make 3D models for us. Here's some of the 3D models that he's got made. I've been doing, spear capsule reconstructions, and I've gone from using the allograft to the tensor fascia lata. And here's a video of a spear capsule reconstruction being done. And we try to incorporate the cuff over it. So we try to make it anatomic. We do arthroscopic elbow, as I said before, and here's our fellow doing a arthroscopic osteochondral arthroplasty. And you can see some of the video clips here. Here's our fellow Tom Zink, our first fellow, doing the arthroscopic elbow cases. My partner does also open elbow cases, and so he's famous for that. And here's our fellow doing an open elbow case. And this is like a sternoclavicular joint reconstruction we did on a patient that wound up being a runner-up Miss Pennsylvania. We take difficult cases like a non-union after a ladder J. And this is my case, and I did a custom-made allograft bone block, and I crushed the fragmented piece against the native glenoid. And you can see here's a reconstruction, and it was a coal mine, and patient went back to the coal mine, and no recurrent instability, and you can see by the post-operative CT scan healed it. So we do reconstructions like this. You see a humeral glenoid defect, and went ahead and bone graft with a crest, and we came back and repaired it, and he's done quite well. This is a case that has two problems. Has a non-union of the humerus and has a rotator cuff arthropathy secondary to an IM nail. And we went ahead and we repaired the non-union and did a reverse arthroplasty for the rotator cuff arthropathy. And you can see we helped her. And she said, basically, docs, you saved my life. But that's what we want our fellows to be able to do. Take out complex problems and solve them. But a complete surgeon, we want our fellows to be comfortable around the nerves. That's why we spend a lot of anatomy with the nerves. And in fact, our current fellow, we bought him loops to be comfortable with these kind of cases. Another complex case, we had its non-union infected, and it got sent to us. And we had to, with a radial nerve palsy, so we had to dissect out the radial nerve, and fix this. And you can see that here's our reconstruction. And she wound up resolving her radial nerve, and she wound up having a decent range of motion of her shoulder. So my partner also does complex cases. His a terrible triad injury, and he's got a paper on terrible triad injuries. And so you get complex elbow cases also. Here's a patient that had a loosening after this implant. And we went ahead and reconstructed it. It was just humeral loosening. The ulnar component was okay. So we did allograft reconstruction with a plate, and she's done quite well. You can see here's her range of motion, and she's pretty happy. It doesn't look happy in this picture, but she's pretty happy, and she's like 4 years out. Here's another elbow reconstruction where I had to use an allograft composite and cement it in, and she's done quite well. You know, another part and one of the benefits of this fellowship is Dr. Tirianis and I are trained in nerve surgery, and you do a lot of nerve surgery around the shoulder and the elbow. It's not uncommon to do nerve transfers. So you get to feel comfortable doing the nuts and bolts of joint replacement, arthroscopy, but you get comfortable with dissecting nerves out through the loupes or the microscope. So this is a total, complete upper extremity fellowship. So here's an ulnar nerve that's not happy. And, you know, my partner, Dr. Tirianis, is a wizard with the nerves, and we spend a lot of time teaching the fellow nerves, and we teach the fellow how to do nerve repairs. We don't think our fellow is going to be hand surgeons and how to do limb salvage surgery with vessel repairs. We do think our fellows come out of our fellowship and do nerve transfers and do nerve repairs. And that's some of the things that's not included that Tom Zink did on his case logs. You know, here's a great case, a synostosis of the elbow or the forearm, a young girl, and she's got it bilaterally. And we took it out and we did a vascularized posterior osseous interposition. And we did that with our fellow. And you can see she's got great motion now. And she's happy. She's a college student. She can use her arm, and she doesn't have a pain in her shoulder. So you can see, you know, we do a lot of cases. And the other issue is we have a lot of research, and we do a lot of research support. A lot of our research is clinical, but we have the opportunity to have a biomechanical lab right in our basement, just right down from our clinical facility. And we do anatomy there, and we do research. We have a shoulder machine, we have an elbow machine. And here's some of the things we have done in the past. We have an Instrong, and we can load tendons to failure. We have an elbow machine. Our elbow machine is famous for distal biceps research, as you can see. We have a shoulder machine, and we got a lot of papers coming out. We're using our shoulder machine for different rotator cuff projects. Like here's our current project from our current fellow, Luis. He's looking at a 3D anatomy of the rotator cuff, rotator cable, rotator capsule. We also take great pride in supporting our fellows throughout their career. You know, we've had a lot of fellows, Dean, Dr. Len, Pat McMahon, and I, and we support the fellow. We sponsor them for ASES membership. We do case reviews for boards. If they have any questions, they text us, send us their cases, and we give them advice. We also give them business advice. There's many times they'll call us and they want to transfer the group, and we'll support them throughout throughout their career. We're there for them. You know, here's just a number of publications that Dr. Tirianis and I did, and this is like 2 years old. And you could see throughout our careers, we had many publications and many fellows as co-authors. And this is our fellows as co-authors on just Dr. Tirianis and my research. And there's many more if I included Dr. Lynn and Dr. Pat McMahon. And the third thing is to have fun, enjoy Pittsburgh, and get to know each other. And we have dinners with our wives, with the fellows, and it's a lot of fun. We take our fellows out, and like here's Tom Zink practicing his golf swing at my country club. And here's a picture of Louise and his introductory dinner. And here's Louise, our current fellow, our second fellow, and his girlfriend Bianca. I mean, Louise came from Puerto Rico, and Bianca is the same. And we took him to Sarah's, a great chocolate shop here at Canonsburg, Pennsylvania. So, we take great pride in getting to know our fellows and making sure they enjoy our city of Pittsburgh. And this is, we have fun. We made a fellow gym, and this is the early onset, and we just had the weight room and the treadmill, but we have a lot more to it, and we got it painted, and I think you'll see us on our other videos. So here's us. Here's Pat Mandine and I at the Shoulder and Elbow Society. And so we all get together at the Shoulder and Elbow Society and have fun. And we sponsored a ton of past fellows. Dean and I and Pat and Albert Lynn have. And so, we're there to have fun and enjoy each other's company. And when you guys are fellows, at the end of the year, one of the graduations is going to be in Wisconsin. And we're just going to invite a visiting professor and just chill, do some water skiing, and talk shoulder and elbow surgery. So I hope you really think serious about our fellowship. It's a great fellowship. I think we've done a lot of time and energy in getting all the complete blocks, getting the people support. We definitely have the pathology and the cases. And there's 4 mentors that want to teach you shoulder and elbow surgery. And I want to thank you for your time and your consideration.